Hi, my name is Macy Justice. I'm a senior biochemistry major, and this presentation is part of my honors capstone project. My project goes by the name of Understanding Rural Healthcare in America. When the American Public Health Association was founded in 1872, public health experts weren't concerned about rural Americans. Rather, they were concerned with the health status and sanitation practices of urban residents in urban areas. However, as public health interventions showed progress in urban areas, the same public health interventions were failing in rural areas. Specifically, interventions related to maternal and infant health were showing little progress in rural areas. As public health interventions began failing in rural areas, concern about rural community health grew. In 1921, the first legislation targeting rural health care was passed. The Shepherd-Towner Act provided funding for prenatal and infant home health visits in rural areas and kicked off a century of healthcare legislation targeting rural health care. States with larger rural populations are also less likely to adopt healthcare interventions and legislation that would assist in closing gaps in rural healthcare access. For example, states with large rural populations are less likely to adopt tobacco control policies, HPV vaccination recommendations, or expand their Medicaid programs. Therefore, the politics of rural populations can actually keep the necessary aid and help out of rural communities. We often use rural, medically underserved, and medically underserved interchangeably. These definitions, though, are not always interchangeably, and different policymakers and different departments in the U.S. government use rural to mean different things. So, according to the Economic Research Service of the U.S. Department of Agriculture, ERS researchers delineate counties based on the classification of metropolitan and non-metropolitan areas. Metropolitan areas, according to this definition, are a central county with one or more urbanized areas, and outlying counties that are economically tied to the core counties. Non-metropolitan areas are separated into two categories, micropolitan and non-core. Micropolitans have a larger labor market, and they're not always connected to a metro area. These areas may or may not be counted in the rural definition, depending on the policymaker or the researcher. Non-core areas, however, are always classified as rural. The U.S. Census Bureau has a different definition of rural. They use a statistical definition that's based on population size and density and that's not influenced by economic ties. Rural areas for the U.S. Census Bureau comprise open country and settlements with fewer than 2,500 residents. The U.S. Census Bureau then delineates urban areas as urbanized areas or urban clusters, with urbanized areas having a larger urban nucleus than an urban cluster. Both of these definitions, however, can be problematic. The U.S. Census Bureau definition tends to classify anything that's not classified as urban is classified as rural, which is an oversimplification of what rural actually is. And the ERS definition tends to over or underclassify areas based on economic ties. So if one part of a county has an economic tie to a metropolitan area, that city is counted as metropolitan or micropolitan, whereas the rest of the county might actually be rural. Now, what is a medically underserved area? While medically underserved and rural are often used interchangeably, they are not technically interchangeable when it comes to the definitions. A medically underserved area or population is defined as a geographic area or a population with a lack of access to primary care services. So whereas rural doesn't have anything to do with whether there are medical services, medically underserved areas or populations rely on the presence of primary care services to delineate whether it's medically underserved or not. But then there are these things called health professional shortage areas that are designated by the federal government. And this is a population or geography with a shortage of providers for an entire group of people within a defined geographic area. So a health professional shortage area might be the same as a medically underserved area, or it might not be, and these areas may or may not be rural. We'll first discuss barriers to healthcare access that rural populations face. The first and most common barrier is a lack of insurance. This type of barrier is not specific to a rural population, but we see it to have a stronger effect in rural areas. So rural areas have higher rates of chronic disease and risk-taking behaviors, but they have lower levels of insured populations, meaning the people that need healthcare access the most are not always able to access that healthcare because they can't pay for it. And then rural residents tend to have a different definition of sick because in rural areas, in the politics of rural areas, there's this emphasis on self-reliance and self-care. Most people don't assume that they're sick until they can't go to work. And then it might be too late to seek a preventative option. They might actually need an emergency room or an acute care type of facility. Then the last and probably the most obvious is distance. Rural areas have to drive further for basic diagnostic imaging, even primary care. But what should be noted is that distance is relative. So if it's something really important, most rural residents will find a way. And because they really just relate the distance with a way of life in rural areas. However, if it's kind of a nuisance to keep traveling, that's when distance becomes a barrier, or for someone who doesn't have a car or is not as functional and not as mobile as someone in their 20s or 30s would be. So distance as a barrier is relative for rural residents. So there are also barriers for rural healthcare providers trying to practice in rural areas. The first is rural healthcare providers experience multiple roles with their patients. Not only are they a healthcare provider, they might be a neighbor. Their patient might be the soccer coach of their kids. They probably are going to see their patients in the grocery store. And this is really where confidentiality can be broken. So confidentiality is another barrier. So that patient might be asking for healthcare advice in the grocery store, and that's not really how to keep things confidential. But because it's a small town, it's likely that the people working in the healthcare office also know the patients outside of that healthcare facility. And so there's a chance for confidentiality to be broken, especially if family members might be interested in why their family member is visiting a healthcare facility. And one of the next barriers is technology. Rural areas have less diagnostic technology and just older technology in general. So for a healthcare provider to be able to do their job, they might have to send patients to a higher level facility further away. And the last barrier that rural healthcare providers face is career progression. Oftentimes, especially for primary care workers, there isn't a ladder to climb, it's just their practice. So they can build their practice, but they're not going to be climbing a ladder in a hospital to a department chair and then overseeing departments. It is just them. And then the healthcare system itself presents several barriers to sustainable rural healthcare. So within the healthcare system and the training and education of doctors, there's this uncoordinated growth. So medical schools have recognized the need for more primary healthcare providers. So they're accepting more people into medical school. But what we call graduate medical experiences, or more commonly referred to as residencies, the number of physicians for these GMEs are not growing as fast as the number of people being accepted into medical school. So we're producing a large sum of medical school graduates, but there aren't enough positions able to train those graduates. So there's this uncoordinated growth that is not really helping. And then the geography of these medical schools and residencies is also a barrier. 99% of all residencies are in urban or suburban areas. So we're training people to be doctors and healthcare providers in suburban or urban areas, not in rural areas. Most people also practice where they go to school or where they have their residency. So if we're sending 99% of our healthcare providers to urban or suburban areas, that's 1% of the doctors trained for the 20% of the US population that actually lives in rural areas. So what are the solutions? Well, a lot of the solutions have to do with resource sharing. So we can resource share with local health departments. We see this currently taking place in parts of Colorado and Wisconsin, where a bunch of smaller local health departments that don't have the resources that a larger health department are getting together and creating a regional network to resource share. Within this, people are able to gain better access to public health interventions than they would if the local health department was just by itself. We also see medical programs such as the WWAMI program or the KCU Joplin program that are specifically training medical school students and residents to practice in rural areas by preparing them for the difficulties they'll face, but also sending them to clinical training early in rural areas. And again, this is a form of resource sharing because the WWAMI program is 5 states, specifically Washington, Wyoming, Alaska, Montana, and Idaho, pooling their resources to at the University of Washington School of Medicine to create these doctors to go back and work in rural areas. We can also see resource sharing when there's a relationship built between a regional ER and primary care providers. Standalone ERs can actually push primary care providers out of the area, but if ERs work together with primary care providers, they can create this nice sustainable base for the regional ER, so there is acute care for the rural residents, while also creating a sustainable base for the primary care provider. And the last, and probably the most obvious in the middle of the COVID-19 pandemic, is telehealth. So this kind of helps limit distance as a barrier, because someone can call from miles away and get in touch with their doctor. This has been used successfully in West Virginia to teach reproductive health, and there's studies showing that older rural Americans are okay with telehealth if it's complementing their in-person visits and not replacing their in-person visits. We'll end today's presentation with a brief case study of McDowell County, West Virginia. McDowell County has an estimated 2019 population of just over 17,000 people. It has a median household income of over $27,000 per year and a population per square mile of 41.5 people per square mile. It was designated as medically underserved in 2010 in the area of primary care. So when we compare the averages of McDowell County to national averages, we see that McDowell County is poorer and more spread out than what we would expect for the rest of America. The national median household income is over $68,000 a year, and the national population per square mile average is over 90 people per square mile. Of the population that's in McDowell County right now, 33% live in poverty, and over 22% are over the age of 65. Of the population that's under the age of 65, 25% report a disability, and 11% report not having insurance, according to the U.S. Census Bureau. There is only one acute care facility in McDowell County, West Virginia, and that is the Welch Community Hospital. This is a state-owned and maintained hospital that serves McDowell County and the surrounding counties. There are local community health clinics, but any sort of acute care will be referred to the community hospital. However, this community hospital does not have every specialty that it needs to take care of all acute situations. If you arrive to this community hospital in an emergency where you need a certain type of specialty, a very specialized surgery, you'll be referred to a larger hospital in a more urbanized area, and you will have to travel to that hospital by ambulance, more than likely. So there are barriers to access in McDowell County, West Virginia that we've already discussed, such as distance and transportation. So McDowell County residents are really spread out, so they travel further to access healthcare. They also have to travel on a mountainous terrain, which makes it even worse. They also have a lack of insurance in McDowell County, and McDowell County is poorer than the average county in America. Both of these having a synergistic effect to make accessing healthcare really hard. There's also a general lack of providers for specialty care in McDowell County. So if you need some sort of specialty care that a primary care provider cannot provide, or you cannot find at the community hospital in McDowell County, you'll be traveling. So then we go back to distance and transportation as a barrier to access in rural healthcare in McDowell County.